Welcome to Chapter 32, Musculoskeletal and Trauma for the EMT. So, quick overview. The musculoskeletal system includes bones that provide the framework for the body, joints for bending, and muscles for movement. We have cartilage for flexibility, ligaments and tendons. Ligaments connect bone to bone, and those tendons connect muscle to bone. So, anatomy of the bone. These are formed of dense connective tissues. They are vascular and susceptible to bleeding on injury. It is covered by the periosteum. And then we have joints where bones meet to allow for bending. Bones are classified by shape. They can be long, short, flat, irregular. Long bones include like the humerus, the femur, the radial ulna, tibia, fibula. All those are long bones. Short bones would be your fingers, your toes. Let's see. Ribs would be a short bone. All those would be a short bone. And then you've got your flat bones, which would be your scapula. And your manubrium, sternum, sorry. And then irregular bones would be your your tarsals, your metatarsals, and your tarsals in your hand. So bones do have a self-healing property. A break can cause soft tissue swelling and a blood clot in the fracture area. That interruption of the blood supply causes cells to die at the injury site. And then cells further from the fractured divide rapidly, forming tissue that helps heal that fracture and develop into new bone. Muscles. So we have three different kinds of muscles. We have the skeletal, which is voluntary, the smooth, which is involuntary, and the cardiac, which is myocardial. The cardiac is obviously in the heart. Smooth muscle is all of those like digestive system muscles that allow the digestive system to work. And then voluntary is anything fingers, nose, or, I'm sorry, fingers, legs, all those. And then cartilage helps move, helps form the flexible structure of the body. So like the nose, the ears. There's cartilage in the ribs as well. So tendons allow for the power of movement across joints. So muscle to bone, muscle, tendon, bone. Ligaments support joints by attaching bone ends to allow for stable range of motion. So bone, ligament, bone. General guidelines. So injury to bones and connective tissues. So we can have a fracture, and it can be a fracture is any break in a bone. It can be open or closed. The bone does not have to be sticking out for it to be open. If there's a wound over a break, that is considered an open wound or an open fracture. There are several different types of fractures. You can have green stick, spiral, comminuted, transverse, and compound fractures. You can also have an angulated fracture where it's bent at an angle. So yeah. You can also have some, we talked about that potential blood loss from fractures. So with the humerus, you could have 1 to 2 liters of blood loss. Again, in the body, we're at like 4.5, 6 liters of blood in the body at any given time. So if you lose 2 liters of blood, that's quite a bit. Okay. Your pelvis, 4.5 up to 4.5 liters of blood can be lost. So you're not going to have a whole lot left. Okay. Femur is at 1 to 2. Yeah, so you can have some blood loss with a fracture. So you can also have a dislocation, a sprain, or strain. Dislocations is where the joint comes apart, and sprains are some type of stretching or tearing of the ligaments. Sprain is a stretching or tearing of the ligaments, and a strain is overstretching or overexertion of the muscle. Okay, and again, they can be open or closed. Not all injuries can be confirmed as a fracture in the field. We're going to treat all injuries with signs and symptoms of a fracture as a fracture. Traction splint should be applied to a suspected femur fracture, and splinting an injury with a suspected fracture helps prevent blood loss from the bone tissue. Rapidly identify and treat any kind of life-threatening conditions first. Be alert for injuries besides that grotesque wound. It's going to be a distracting injury for us and the patient, because they may have some type of internal chest injury that we may not see, but hey, that's an open femur fracture and the bone is sticking out. That's pretty cool. So it's a distracting injury. So be alert for that. We're going to cut or remove the patient's clothing to complete an examination. Again, if your patient is not trauma naked, then you can't assess them properly. Compartment syndrome. So this is where we get severe swelling in the extremity as a result of the fracture. It has a progression. So we have a fracture or crush injury that causes bleeding and swelling in the extremity. The pressure and swelling becomes so great that the body can no longer perfuse the tissues against the pressure. And then we also have some cellular damage that occurs, causing additional swelling. And then we have blood flow to the area that is lost. The limb may also be lost if that pressure is not relieved. They're going to have some pain and tenderness, deformity and angulation, maybe grating or crepitus. Crepitus is where we get the bone-on-bone rubbing sound. Doesn't sound very pretty. Exposed bone ends, swelling and bruising, joints locked into position, and then you can also have some nerve and blood vessel compromise. When we look at a fracture, we look at these 6 P's of assessment. So pain and tenderness, pallor, paresthesia, that pin and needles feeling, pulses that are diminished or absent, paralysis, and pressure. Take standard precautions, perform your primary assessment, do a secondary assessment. If you suspect a spinal injury, of course, apply a C-collar. Splint any kind of suspected extremity fractures after treating your life-threatening conditions, and cover any kind of open wounds with a sterile dressing. Splinting, so it does have its advantages. It minimizes the movement of the disrupted joints and broken bone ends. It decreases pain. It prevents additional injury to the soft tissues, the nerves, the arteries, the veins, the muscles. And it can also prevent a closed fracture from becoming an open fracture and minimizes that blood loss. So realignment. When we talk about realignment, we don't necessarily talk about putting the bone back together, even though that's what we're doing. Basically what we're going to do is we're going to put it in the position of function. Each joint or bone has a position of function. So like the hand, the elbow, the shoulder, all of those have a position of function. And it's not the anatomy, a standard anatomy view. This is the position of function. So what is my hand designed to do? It's designed to grip. So position of function is gripping for the hand. My hand is designed to flex. Okay, so position of function is either flexed or relaxed, one of the two. My elbow is designed to hinge and bend. So position of function is bent. My shoulder is designed to move up and down all around. Because it is a different kind of joint, though, we're going to just kind of put it in downward position, typically with the elbow bent. But realignment can restore effective circulation to the extremity and to simplify splinting. If it's not realigned, splinting may be ineffective and cause increased pain and possibly further injury. They have an increased chance of nerves, arteries, and veins that of being compromised. They may have an increased pain. When you do the realignment, it's only going to be momentary. Typically, the patient's going to be the pain is going to go subside substantially when it gets realigned, if it can be realigned. So it's only going to be momentary for an increased pain, and then it'll subside. Typically, what we do is before we remove any patient, before we splint them, before we do anything, we give them pain meds and let it kick in before we do any of that. We're going to splint in the position found unless the distal extremity is cyanotic or lacks pulses. And if the extremity is cyanotic or lacks pulses, we're going to align the joint to a neutral position using gentle traction. So one person grabs the distal extremity while the partner places one hand above and below the injured site. The partner supports the first EMT, who creates gentle manual traction in the direction of the long axis of the extremity. So if I'm holding the elbow, my hand is over here in my left hand, and my elbow is over here on the right hand. So I'm going to hold I'm actually going to hold just above the elbow on the humerus, and I'm going to hold the wrist, and I'm going to pull away from my hands. So I'm going to pull the wrist towards the outside of the body, towards the other opposite side of the body while I'm holding on to that humerus. If no resistance is felt, maintain gentle traction until the extremity is properly aligned and splinted. Strategies for splinting. So effective splinting may require some ingenuity. I don't know that I've ever splinted anything the same way ever, because all of them have been weird. So it may take some getting used to and trying to figure out what works. I'm just going to tell you what works for me when we go through these and how I can do that. So there's 3 types of available to us. There's traction splints, rigid splints, such as the backboard and the splint boards up there. There's formable splints, such as the SAM splint, and then there's the traction splint. There's also so this one right here is the Sager, right there in the middle of your pictures. That's the Sager. It's a bipolar device where you can actually put both legs in the device. If they have like bilateral femur fractures, you can put both legs on that device and traction both legs. The Hare's traction splint is a single or unipolar traction device, and it only does one leg. And then there's also the KTD, which is another unipolar device. We're going to care for any kind of life-threatening problems first. Expose the injury site. Assess distal circulation, sensation, and motor. Align the long bone injuries to the anatomical position. Do not push protruding bones back into place. Mobilize both the injured site and the adjacent joints. Choose a method of splinting and splint before moving the patient to the stretcher or other location if possible. And then we're going to pad any kind of voids as well. Okay, so there are some hazards of splinting. You can splint to death, where we are splinting before any kind of life-threatening condition is addressed. so not ensuring those ABCs. You can splint too tightly, where it compresses the soft tissues and you lose your PMS, or you can splint too loosely, that allows too much movement of the injured site. And then splinting in that deformed position. We don't want to splint in a deformed position. Splinting long bone and joint injuries, so take appropriate standard precautions. If possible, expose the area and manually stabilize the injured site. Assess PMS, realign if deformed, or if the distal extremity is cyanotic or pulseless. Measure or adjust your splint, move it into position, apply and secure the splint to immobilize the injured site and adjacent joints. Reassess your PMS distal to the injury. In a traction splint, this counteracts the muscle spasms and greatly reduces pain. Again, you can have bipolar, unipolar devices. The amount of traction applied should be roughly 10% of the patient's body weight, not exceeding 15 pounds. Okay. Take standard precautions and, if possible, expose the area, manually stabilize the leg, and apply manual traction. Assess the PMS to the injury, or distal to the injury, and then adjust the splint to the proper leg length and position it at or under the injured leg. Depending on which device you use will depend on whether or not you put it at the leg or under the leg. You're going to apply the proximal securing device, the ischial strap, and then apply the distal securing device, which is the ankle hitch. I'm going to actually show you to place the ankle hitch first, and then go and apply everything else, and I'll show you why when you guys come for skills. Reevaluate the proximal and distal securing devices and reassess PMS. Secure the patient's torso and the traction splint to a long backboard to immobilize the hip and prevent it from movement. Alright, so let's talk about some specific injuries. So shoulder girdle injuries. They're going to have pain in the shoulder, they're going to have a drop shoulder, and they may have severe blow to the back over the scapula. Assess PMS, use a sling and swath. If there's evidence of anterior dislocation of the head of the humerus, we're going to place a pillow between the patient's arm and chest. Do not attempt to straighten or reduce the shoulder, and reassess PMS. Pelvic injuries, so they can have pain in the pelvis, the hips, the groin, or back. They may have some pain when pressure is applied to the iliac crest. They may not be able to lift their legs when they're laid supine. Lateral rotation of the foot, unexplained pressure in the bladder, and bleeding from the urethra, rectum, or vaginal opening. So they can have an anterior or a posterior hip, we're talking about pelvic. They can have an open book pelvic fracture or a closed pelvic fracture. So an open book, remember down at the bottom of the hip, the pelvis, we have the a little space in there that's basically like got connective tissue in there, and if that opens up, that causes an open book fracture, and causes the legs to be spread apart. We're going to move the patient as little as possible. We're going to determine PMS to injury site, straighten the lower limbs to the anatomical position, stabilize the lower limbs, and assume spinal injuries. Reassess for distal PMS, care for shock, provide high flow to transport, and monitor vital signs. So there's a couple different options that you can use for splinting a pelvis. the easiest, most effective way for us is to use a sheet. And we'll show you that when you come for skills. But there are also commercially available devices out there that you can use to do this. But a sheet works just as well and is just as effective. Hip dislocations. These can be anterior or posterior. With an anterior, obviously the hip, the ball of the head of the femur has come out of the hip joint, and it's pushed forward in front of the pelvis. Whereas in a posterior hip dislocation, that ball of the head of the femur has popped out and it's in the back. This patient's going to have inward rotation of the leg. They may also have the knee may be also bent. That foot may also hang loose, and they may be unable to flex the toes or lift the toes. Okay, and they'll also have a lack of sensation in the limb. With a hip dislocation, we're going to assess distal PMS, move the patient onto a long spine board, immobilize the limb with pillows and blankets, secure the patient to this backboard, reassess distal CMS, care for shock and transport, monitor vital signs, check for nerve and circulation impairment. Older patients are more susceptible to these hip fractures because of their brittle bones and weakness from various diseases. So a hip fracture is where we have pain that is localized. It's sensitive to pressure exerted on the greater trochanter, which is that big, huge ball-looking thing at the top of the hip. Surrounding tissues are discolored. Swelling may be evident. They may be unable to move the limb while they're on their back. They may also be able to not be able to stand. The foot on the injured side turns outward, and they may also have some shortening. So we call that rotation, shortening and rotation for that. Place a folded blanket between the patient's legs and bind the legs together with wide straps or wide cravats. Use thin splints to push the cravats or straps underneath the patient at natural voids and readjust so that they will pass across the chest. The abdomen just below the belt and below the crotch, below the knee and at the ankle. Yes and no. Again, we're not transporting patients on a backboard, even though this is splinting. Even though this is splinting, we can splint the legs together basically for a hip fracture. This does not work for any other type of fracture, like hip dislocation or a pelvic fracture or anything like that, because this patient's going to be in pain if it is. Femoral shaft fractures. So this is going to cause intense pain, possibly open, and the injured limb may be shortened as well. In that middle picture, you kind of can see some shortening in his leg. We're going to control bleeding, treat for shock, assess the distal PMS, apply a traction splint, and reassess distal PMS after we apply the splint. So when traction splinting through thigh injuries in children, be sure to use appropriately sized splints. We do not carry appropriately sized splints for kids. We don't splint kids' femurs. So knee injuries, so dislocations are typical in a knee injury. Pain and tenderness, swelling, deformity with swelling. They're going to assess the distal PMS, immobilize in the current position, and then reassess. Typically, though, what's going to happen is if it is a dislocation, the patient is going to it's going to be kind of funny because when you move that patient, because when you get there, they're probably not going to move, but when you tell them that we need to move them to get them from the cot to the, or from the ground to the cot, um, their knee is going to pop back into place, and typically, and they're going to be much better. Now, am I saying they still don't need to go to the hospital? Absolutely not. They still need to go get an X-ray, make sure that it is back in properly, and yeah. Tib-fib injuries, pain and tenderness, swelling, possible deformities. Um, we're going to apply a vacuum splint or air inflated splint, immobilize the fracture using 2 rigid board splints, or apply a single splint with an ankle hitch. I'm going to show you the rigid board splints because that's what we have. Vacuum splints and air inflated splints, there's not a whole lot of services that still use those, but there are some. Ankle or foot injuries, so pain, swelling, possible deformity. These hurt like a mother. They do not feel good. I was off work for about 4, 5, 6 months because of an ankle injury, and my foot was probably twice the size of this one was when I injured it, and it's still pretty swollen. So, and we're almost a year out. So, assess distal PMS, stabilize the limb, lift the limb, place cravats underneath the ankle and lower the limb onto a pillow. Tie the pillow around the ankle. Pillows work really well for ankle or foot injuries. It basically allows them to have a soft spot to put their foot on, and allows them to have some type of bulky dressing around that ankle to protect it. Tie a 4th cravat at the arch of the foot. Elevate with a 2nd pillow or blanket. Reassess distal PMS. Care for shock if needed, and apply a cold pack as needed. Forearm, wrist, and hand injuries. So signs, again, any kind of deformity and tenderness. In the hand, it'll be deformity and pain. They may have some dislocated fingers as well. With a hand injury, we're going to just splint in that position of function or position found. And I'll show you a wrist, how to wrap a wrist and everything like that when we do skills. So if you have any questions, let me know, and I will answer those to the best of my ability.